This is the video of laparoscopic appendicectomy in perforated appendicitis with generalized peritonitis. The patient is in pediatric age group, I think it's around 15 years of age, and I took as an emergency surgery and CT done, and it shows the collection and the right iliac fossa. And so that is like a moss like and localized guarding. So that's why I put the first trocar is epigastric trocar. So that is relatively free area. So I don't want to put in the moss area. So after that is just below the costal margin in the midline I made this trocar. Under vision I made this umbilical and suprapubic trocar. So I made umbilical trocar always 7 mm in appendix. So most of the appendix I will take through the 7 mm. Sometimes I change to 10 mm. Suprapubic is always 5 mm for a camera. So that is the symphysis pubis. I am making a camera just above the level of pubis. So taking a camera in a suprapubic port, and you can see this omental covering in the right iliac fossa. So a lot of collection, you can see the collection pus, frank pus in the paracolic region, subhepatic and subdiaphragmatic. You can see the subdiaphragmatic collection, subhepatic region, thick pus. It is delayed presentation. The patient was admitted in outside hospital. They treat like a diarrhea history is there, so they treat like a colitis, and already he developed the peritonitis. Fecal matter also perforated is coming. So first line, this is you have to give thorough wash before starting the procedure. So I am taking the omentum. So first is the omentum. I have to take the omentum up, find out the pathology site, place the working port, left hand working port. This is the pelvic collection. I am just taking the clearing the collection. So that is the pelvic wash is being given, and you can appreciate dilated bowel. The space is less. So a lot of plaques is there. It is already 48 hours old. I think 72 hours old presentation, and you can see a lot of thing is coming from the pelvis. So always when you see the pouch of Douglas, and then you can irrigate from the pouch of Douglas so that everything will come out. You can aspirate. So pathology is in the right iliac fossa. So I am making the port in the right iliac fossa. Anything on opposite side. I am standing on left side. So right side of the patient, I want to make a trocar port. I use like this. My left hand, I keep like this trocar. So you can see this little finger will prevent the trocar to come out when I introduced it, and then this thumb will be the guidance. So only this much will enter inside. So I used to keep my you can see my free movement of the instrument, wrist, and then controlled way we can enter inside. So this is the way I used to do trocar opposite side of me. I use my left hand for the making the trocar. So this is the camera, suprapubic, right hand working umbilicus, left hand working in right iliac fossa. This is the 3 port. The epigastric port is the entry point. Because of the mass formation, I don't want to go in the umbilical region. So this is the cecum and ileum. Identify the structure, that is the ileocecal junction is seen, and that is the fixed portion of the ileum, terminal ileum, that will be the ileocecal junction. So everywhere collection is there. So that is the omental covering. I am taking out the omental covering. That will be the first step. Basically, omentum is called abdominal policeman. Anywhere is infection, it will go. But in appendix, what I am observing is the first thing is going is the this one ileum. Ileum is go and cover the first time. And if it is a pelvic appendix, epiplaque of the sigmoid colon will come there and then will cover it. Great omentum is the last one to cover. So that's why we have to take the first one is the greater omentum. That is the last one to cover the pathology site, but during surgery we are taking it first one. So it's a little different thing we are noticing in laparoscopy, and most of the time ileum, since it is a ileum is adherent, terminal ileum is not going there in this case, and most of the time ileum will be go first, then colon. If it is a pelvic area, then comes omentum. So you can see I am not doing appendicectomy now. So I am giving a wash, taking out all the plaques. So this wash will reduce the bacterial load in the peritoneal cavity so that the recovery is fast. Usually I ask the staff nurse to make a warm saline. I used to do with 4 and 5 liters of warm saline. Usually it come with 1 liter this one plastic bottle. So they put it in a warmer, and then it will be warm saline, and 4 liters or 5 liters is required minimum to wash the entire all quadrant of the abdomen. So first thing is give thorough wash, reduce the bacterial load, then do the procedure. Finally, again you have to do it wash. So this omentum is covering the pathology side, so I am washing the omentum. You can see all the plaques. I am taking it out, and then it will be it will be sucked by the suction nozzle, and no need to remove with the instrument. The suction nozzle is enough. So that is the appendix. I could able to find out tip, and then this is the perforated site. You can able to see the perforated site. It looks like coiled curved appendix with the perforated site. That is, a tip is free lying appendix, and most of the appendix is here is a peritonized. So I am taking a harmonic scalpel. You can use a bipolar, but harmonic is ideal. You can see both the instrument is on towards the right left fossa and camera is in the suprapubic. So it is a very good ergonomics, and again I am emphasizing that it is. You can see that I am very comfortably I am standing, and the entire team is very much comfortable. I don't have a shoulder strain. So this will give a very good view and good ergonomics, and almost all the appendix we can able to tackle with this port. I think this is the 9th or 10th video I am uploading. All cases I am using only this port. Only the pelvic position I do it a different position, different port. Otherwise all the appendix I could able to manage with this port. So I am dividing the meso appendix with the harmonic scalpel. If you have monopolar or bipolar, sometimes you require clip to the divide before division, but harmonic is a good enough, you can divide. So it is one of the very good instrument for appendicectomy. So I am just dividing the meso appendix. From here everything is fixed. You can see I am dividing the peritoneal covering of the appendix. So I am just separating the cecal wall from the appendix, cecal wall, and this is the meso appendix is also there. So here the peritoneal reflections I am dividing. So in between that looks like a base, that look like a base of appendix, that is relatively looks normal compared with the other part of the appendix. So that is the IC junction, ileocecal junction is very clearly seen, that is IC junction. And you should not divide the appendix at the level of perforation and then apply loop, because the base is a different place, that is the base, so it's curved. So always try to understand the anatomy, then go ahead. Don't rely on base perforation or put loop in the base, no. It look like a peritonized and the entire thing is like a mass. So we have to do very carefully, so that always appendix will be you have to trace up to the cecum. So again I am using harmonic scalpel. So without any bleeding, without any lateral thermal spread, not much thermal spread with the harmonic scalpel. So the cecal wall and other structure will be prevented, thermal injury will be prevented compared with monopolar and bipolar. So that it is safer than any other energy device. I am taking out the cecal wall and the peritoneal covering. So almost the curved area, I came. So that side is cecum, this side is mesoappendix. Always go close to the appendix when your appendix is lying on the cecum. Always try to go close to the appendix. Again, I have to give wash in that area before division of the before proceeding further. So I'm now you can see it is like a normal, not much damaged base of the appendix. So give was and then decide. Sometimes without washing will give the clear your anatomy. Any surgery in between give saline wash and then clear that area if you see, you will understand the anatomy better. Even in acute gallbladder, don't do continuous surgery, give wash, retract nicely and then see the anatomy and then proceed. So same like I am doing it here. And otherwise no, if you go and then sometimes the cecal wall get injured. Now you can see it's like a little bit conical cecum. I don't want to release the cecal adhesions because already base is reached. If I have any doubtful, any doubt in the base of cecum, then I mobilize the cecum. Here this case I don't have any doubt. You can see good length of appendix is there below the level of perforation. So I am milking out all the content. I am going to apply the endo loop. After perforation, the pain will be decreased, and the patient is treated in outside hospital like a colitis, for a diarrhea, and then they realized, and then the patient came to our hospital, and then I took emergency appendicectomy. So the catgut loop is applied to the base. First loop is just occlusion, don't tight very much, just tightness is enough. Again I am milking it out. The content will go to the body of the appendix. So I am applying the second loop. So this is our practice. Many surgeons they are doing it with only one loop, and some surgeons they are doing it, they are applying the clip to the base of the appendix. A lot of surgery, a lot of article is there, and I could see one or two articles from Bangladesh. So clip to the applied to the base, and then they are hemolog clip to the base, and then they are dividing. But our practice is always this endo loop, two endo loops with the catgut with the 2 to 3 mm distance. This loop you can tight very well. And the standard teaching is you have to apply the third loop, and then you should not divide the loop, you have to keep the loop. That loop is keeping the appendix so that appendix will not fall anywhere or will not miss anywhere. So that is a standard teaching. So I am just showing that one, and you can see this loop you can move up and down very well. You have to see to that that loop it should not touch the appendix. If a loop is touch the appendix wall, then it will not move. So it is loose, so that I tightened it, and actually I put this loop so that the content will not come out from the appendix when I dividing it. That is the purpose of this third loop. So I am dividing the appendix, and I convert into 7 mm to 10 mm. I am taking out through the 10 mm because this appendix will not come to the 5 mm port. So it's a 10 mm port. I am taking out the appendix. You can see how much big length of appendix is taken out. And always the stump will be sterilized with betadine. The exposed mucosa of the appendix I am sterilizing with the betadine gauze piece. And those days in the late 90s and early 2000, we used to apply cautery to the mucosa. To sterilize the mucosa, apply cautery. That cautery will go to the base of cecum. That's why nowadays we are not doing it. So again, another important step is washing. You can see I am started washing the entire abdominal cavity. You have to give thorough wash, and before that I started doing Meckels, and that is the fixed portion of the small bowel, terminal ileum. So I am starting there. And what happened is you can see this plaques is there. So this will make this loop adherent one to each. Now you can see the interloop adhesions. If you are not taking it out and then give wash, this will loop adherent together, and postoperatively the patient will have ileus, already dilated loop adherent together. It will produce postoperative ileus or subacute feature, obstruction feature. So always you have to do bowel walk nicely, and you have to give thorough wash in between the loop. So that bowel adhesions postoperative will not be there. This is very, very important. So I'm washing this. So now that instrument is coming from right iliac fossa, I'm taking the epiploic colon, and then rectum is retracted. Pouch of Douglas is seen very nicely. So again I'm taking doing the bowel walk. I'm placing the entire bowel into the proper abdominal cavity, so that I can able to give wash in the pelvis nicely. No bowel will be in the pelvis. So wash in the pouch of Douglas I can give thoroughly. Entire bowel is dilated. It is a paralytic ileus is already there. So here not much plaques. So anyway, I have to give was on all the 9 quadrant of the abdomen. You can see, in the pus like, stick is there, it is there also, it is there. So I have to give was. So epigastric port I am using now to retract to hold the bowel. So now you can see the instrument is coming from the epigastric port holding the bowel. Now you can see this pelvis with the rectum only, and that is the instrument from right leg for support. So I am giving was in the pelvis. So now the camera is in suprapubic port. So with the suprapubic camera port, you can see how much pelvis is able to see, and then you can give a very nice was. You can see the entire pouch of ductless. Again, I am going to the subdiaphragmatic plane. You can see the pelvis, subdiaphragmatic, paracolic, all there. Even left is subdiaphragmatic area, also spleen area. Also, I used to wash. During the time of wash, I wash this omentum also, because this is the covering the infected site, pathology site. I am trying to take this omental plaques, however it is coming, and at the end of the surgery, if you see, almost entire this plaques will be removed, and through the suction only, once it is removed, and then you can suck it out. No need to take it through the instrument port. So it is being sucked out. These are all produced some pleural effusion also in some patients. Because of the pain, they won't breathe well, and then atelectasis, again hospital stay will be increased, and fever, antibiotics, so many things. So if you give thorough wash, and the entire bacterial load will be cleared, and then remaining bacteria, the peritoneum will take care of the remaining bacteria. Anyway, the source is removed, and the recovery will be fast. I used to keep only 1 day after the surgery. Once the bowel started functioning, then I will discharge the patient. Now you can see I am washing in the left hypochondrium, left diaphragmatic surface area, and you can appreciate the pus content there, fluid. So epigastric also below the liver, stomach, lesser curvature area. So again I wash entire area. Now you can see I am washing there. All the collects, all the area will be washed out. And for this, epigastric port is helpful. So it is very nearby, we can able to give wash. Washing the peritoneal cavity is the key step, considered very important in a generalized peritonitis. When laparoscopy initial time, they told you cannot wash all the quadrant. Now I am showing all the quadrant how I am giving washing, and you can see it will be, everything is cleared, all the infected material is cleared from the peritoneal cavity. So it is very well possible in any case, even DU perforation or any case, we used to give wash like this. Entire area we can give wash. We got to spend half an hour, 40 minutes extra to only washing. And I used to give normal saline. Now you can see the pelvic side, it is a very clear water. It's a collected water, it's a clear. Now you can see I went to the upper end, that is a head end of the patient. I am giving washing on the left left iliac fossa. You can see my instrument is focusing towards left iliac fossa, even camera is on the left iliac fossa. So left paracolic and left iliac fossa, you can able to give wash. If you have extra monitor, it will be useful in the foot end or in the left side of the foot end. But anyway, for 2-3 minutes we can. So now we can see the sigmoid colon and the pelvic brim. So left side I am giving washing. So all the area we have to give wash, and in between the loop we have to give bowel walk around 2 to 3 meters, and in between, now you can see the saline is like a relatively clear compared with previously, and all the plaques I removed. You can able to appreciate lot of plaques came when I give wash initial time, and even the pelvis also lot of plaques was there, so I removed it. So now I am seeing, I am going to the cecum. paracolic area, divided appendix stump. I'm looking for appendix stump. It's good. So paracolic area. You can see all the plaques are removed. You can see the cecal wall. It is adherent to the lateral wall of cecum. Appendix was adherent to the lateral wall of cecum. So I'm doing a port closure since it is a 10 mm port in the umbilicus. It has to be do full thickness port closure device. This is the 10 polyamide, 10 ethylon. Sorry, number 1 ethylon. I used number 1 ethylon. Single, not a loop, only single thread. I'm introducing the trocar again. I'm keeping a drain. Drain means some vas fluid might be in between the ileum or mesentery. So that I'll keep it one day. Once the bowel started functioning, patient started passing flatus, then I'll remove the tube. I replace the bowel into the proper from the peritoneal cavity to the pelvis. Some one IV antibiotic, and next day patient can be discharged, or second day patient can be discharged. Depends on the recovery of the patient. Depends on the bowel movement. So this way we do appendix abscess with the generalized peritonitis. Thank you.